Right, those of you who don't know me, I'm Norman Long, and I've been a member of the ABPN since 1976 and was kindly honoured year before last as a fellow. So I've been a children's nurse I was a children's nurse for 48 years and then retired. And I've been working with the Children's Hospice. I've been dealing with this particular family now for over 10 years, which is why they've given me permission to talk about him. And it's quite a complex case. So I've done the slideshow, and I'm hoping that I've done justice to the family as well as the child, and hopefully I'll give you a lot of things to think about. So the child is now 17 years old. He lives with his parents. He's got two older brothers, both of whom had serious health problems. The eldest one was born with spinal problems and had to have spinal surgery within 3 months of birth. The second son was born with major heart problems and had cardiac surgery within the first 3 months of life. And then they were advised that during this pregnancy, in the third trimester, the test showed that the child was going to have major developmental problems. He's non-verbal. He's classed as blind, partly because nobody can actually do a test on him to show whether he can see anything at all. He does blink and he does move his eyes and he does react to stimuli. He's got epilepsy and he has a vagal nerve stimulator in situ. He's wheelchair bound, non-weight bearing, unable to swallow, so he's nil by mouth, and the only medication we can give is the emergency midazolam when he goes into status epilepsy. He very often requires frequent suction rapidly because he can't swallow anything. So if he gets a lot of saliva or phlegm or coughs, you have to grab your sucker quick and suck it out to stop him inhaling and cause an airway blockage. He's got a gastric peg tube, so that's a major problem for the family as well. He's got sluggish bowel, possibly because he's only fed with fluids and not enough fibre in the milk. So twice daily, the family pass a flatus tube to relieve gaseous distension and to try and stimulate the bowel to get debris out. And it can take about 25 to 30 minutes to do the procedure, lying down on the bed. He's got no upper body muscle power, so he can't raise his arms, and he's got contractures affecting both hands in particular, so he can't do anything except a palmar grasp. So if I give him my thumb or my finger when I'm talking to him, he can wrap his fingers around that, but that's all he can do. He doesn't move his limbs voluntarily, so only when he has the seizures, and he doesn't do major shaking, but it means he can't turn over, repossess himself, move his legs, so we have to watch that he doesn't develop pressure sores. Because he does a lot of mouth breathing, he gets a very dry lips, very dry tongue, and is prone to fungal infections of the mouth. So as well as the oral suction, we need to do oral hygiene, preferably 4 times a day. He's still got infant teeth as well as his adult teeth, and he's actually got 3 rows of teeth in his mouth. So he's got overcrowding, which is causing gum soreness, and that affects him, and he goes red in the face when he's got the problems. But none of the dentists will actually touch him to take any of the teeth out, because it needs a general anaesthetic, and they're all worried he won't wake up from a general anaesthetic. He's classed as special educational needs and disabilities, so he attends a special school when his health permits, so that he can socialise and have some stimulation, and he does quite well there because they've got a physiotherapist, they've got a hydrotherapy pool, and they do different things with him and take him outside. He loves to be outside in the wind. He loves the wind in his face. He doesn't like being in the dark, but he doesn't like bright sunlight. And then because he's 17, he's now transferring across from children's care to adult services, which is a major heartache for the family. because he's been with the Children's Hospital for 17 years. A lot of staff know him and the family. They know how he behaves. When he was in the hospice, there's regularity of staff rather than bank nurses, so they get to know him. But now with the adult hospital, they're all saying, oh, it's too complicated for us. So what's the daily routine? The parents have to get up, usually between 5 and 5:15 in the morning, in order to start his daily care. At 6 o'clock, he's been on an overnight feed, so they've got to stop that, and then they've got to give him his first lot of medications. All of them should be through the PEG tube. Then about 20 past 6, they have to try and do the flatus procedure to make him more comfortable, get him washed and dressed, and if he's going to school, ready for school, and if not, then he gets dressed into some day clothes. He has medications at 6:45. Then they give him a milk feed at 7:45, and then an inhaler of colomycin through a nebulizer in order to help with his chest and try to reduce colonization of bacteria in particular. Just after 8 o'clock, he has medications, and then you get him ready for school, and then the drive to school, which takes about 40 minutes. Then hopefully he's at school until 2:30. While he's at school, he has a one-to-one care support, and she's been trained to do his PEG feed around 10 o'clock, and then she's been done the training so she can give him his medication. So he has medications at 11 o'clock. Then he has a normal saline nebulizer, 5 mils, to try and keep his chest nice and loose so that it doesn't get too dry. At lunchtime for them, he has to have a milk feed, and then at 1 o'clock he's got medications, and they change his pad when he's soaking wet. He rarely is doubly incontinent, but he needs his pad changing. At 1 o'clock he has more medications, 2 o'clock, and then they get ready for him to come back home. Sometimes if they're late or his mom's late, she has to give him a milk feed actually in the car park while he's back in his disability vehicle with a water flush, because the school want him out of the building, and once he's out of the building, then she's still got to give him his feed. They get home, and the first thing they do is put him on the bed and change his pad, give him a normal saline nebulizer, and then give him a water flush to try and make sure he's got sufficient water in the system. Medications at 4:45. Then he goes into the bathroom, and he likes to go in the spa bath, which takes about 40 minutes to wash him all over and give him time in the bubbles. Comes out of the bath, onto the bed, perform the flatus tube procedure, get him dried, get him dressed. Then he has medications at 7:15, 8:15, and 9:15. And then when he's had the last lot of medications, they start the overnight feed. And about 20 minutes later, they open a Farrell valve, which is designed to try and reduce his abdomen from filling up with too much air. So then hopefully he'll settle down by 9 o'clock, and the family can think about what they want to do and go to bed around 10 o'clock, ready to get up again next morning at 5. They don't get much care at home in the way of support carers. They've got a carer who from the school for extra care likes to come in and help him to get ready for school, and then she'll be his escort to school. Otherwise the parents have to travel to school to take him there and bring him back. So it affects how dad can work and what hours he can actually fit in working, so that he's always got somebody in the back of the vehicle with him in case he has any seizures. When are they going to get time for their own meals, their own care and their own life? He's on a lot of medications, and part of the problem with the medications is that he is now deemed to be an adult by some of the people, some of the pharmacists, so they keep sending the wrong type of medication. And recently he's had the wrong dosages dispensed, he's had the wrong format dispensed, and the pharmacist doesn't want it back, so it's had to have another prescription in order to sort it out. She has colomycin, which is a dry powder, which is mixed with normal saline and then given through a nebulizer. But you can't leave it to stand too long once you've mixed it. And we have to watch some of the carers because he did have a carer when we were at the hospice who was allergic to the colomycin. So she always had to leave the room for half an hour while we were doing the nebulizer for him. I always say to him, give him some oral suction before it so that he's not likely to start coughing during the inhalation process. But I've noticed some of the carers and the parents often forget and just put the thing on. Some of the medications are tablets and they have to be dissolved in water, and then they've got to work out the calculation of what dose he's allowed to have. Excuse me. And so some of the tablets come in the full strength. Some of them is only allowed half of the dosage. And so we've got a problem then trying to make sure that whoever's going to give the medication only gives the correct dose at this point in time. He has clobazam for his seizures. That is a liquid, so that's easy to draw up and give straight away. He has gabapentin, and he has carbamazepine. He has some levomethpromazine, again into a syringe. And then because he's got sluggish bowel, he has Senecot liquid. But the adult hospital is saying he can have Senecot tablets. So they had to explain to him that the Senecot tablets don't dissolve easily. They have tried to do it, and it takes a minimum of half an hour for a tablet to dissolve before you can actually make sure that there's nothing there. They've tried grinding them with the tablet crusher, but it's not always successful, apparently. I've not seen it, so I don't know. He's on clonidine. Same thing, the tablets have got to be broken up and then dissolved and calculate your dose. Lansoprazole, baclofen, phenobarbital, and that's a liquid. He's gone with the adult care services. They are trying to reduce the carbamazepine and increase and put him on a new drug called cenobamate, which is supposed to stabilize the number of seizures that he actually has. The problem is we're in that transition period where you're upping one medication, downing the other medication, and that's causing a problem because he can be unreliable and sometimes he's having little seizures. And the protocol is if he has more than 5 seizures in 5 minutes, you have to give an emergency drug. Or if he has seizures going on for 15 minutes, he has the emergency drug. They use midazolam buccal, so that you've got to give a bit at a time through into his mouth, but he can't swallow. So you have to, I would say to him, quickly grab the suction, suck his mouth out so it's nice and dry, then put the drops in and move them around the mouth so that they're absorbed quite quickly. If that doesn't stop the seizures, then it's deemed to be in status, and so they have to then call 999 ambulance because they have to have an ambulance crew available in case he stops breathing if you give him a second dose of midazolam. If he goes red in the face, it often means he's in pain, and it's the only way he can show pain. He doesn't cry. I've never seen him with tears. He screams very, very occasionally. So then you have to decide to give him some paracetamol liquid, usually through the syringe. But it's trying to decide who decides he's in enough problems, trying to make sure that he gets the right dose when he should do. Now, one of the problems is recently is that he's been in the adult hospital and the pharmacy have sent home the emergency drug of phenobarbital liquid to be given now to try and reduce status. But the new dosage they've given and the format they've given means you've got to try and draw up 16.5 mils while you're trying to watch his seizures, and then administer that as fast as you can. So to me, that seems a bit silly when he could have had 5 mils, which is what the old style was. So there's a lot of different things there for the family to try and think about. And and we'll go on to some of the problems that I've encountered in a minute. So I try to draw up a chart when I've discussed things with the family to say, have we discussed this? Have you been prepared for this? Have you been advised what to do? Do you know where to get your supplies from? And we've drawn up a checklist because we're hoping that he's going to get some community care support. We're hoping that he might get overnight respite care where there's a carer inside the house in his room with him so they can get some proper sleep, but they can't leave the house. So I've drawn up this chart and hopefully I've covered most of the things, but please feel free to adapt it, modify it however it suits you. So the first one that I always talk to them about is when he's got a new drug, do you know why he's going to have it? Because, and they say to me, I think it's because. They rarely often say, yes, this one is for. The only one they seem to know what it's for is the Senecot. The format that they're going to be given, because they've had a different GP who wanted to give them different formats, saying that it was cheaper for the surgery, but it's not safe for the child. Now, the dosages have altered because he's now 17, but there's a reluctance by the GPs and the hospital consultant to change some of the dosages because he's in, whilst he's classed as an adult, they're saying that he's still got the weight and the BMI of a child. Because although he's about 5'9" long and he's about 58, 60 kilos in weight, they don't seem to weigh him very often in order to decide, well, what is the new dose that he should be having? They know the route of administration, but in order to have the route of administration, they've got to make sure that they've got the right equipment, which we'll put underneath, and where to do it all. He's got a lot of medications, and so what the family have done is bought a chest of drawers, and 3 of the drawers are full of medications, because for some reason, the pharmacist and the GP like to send 2 months' supply at a time, which seems daft to me because 1 month at a time is better safe storage. And if the dosage change, then it can be discarded, sent back, or whatever they've got to do when they're doing it. The parents have to watch the stock and know when to ask for a new prescription to make sure it's then sent to the pharmacy on time. It's not uncommon for the mother to go out on a Saturday afternoon or a Sunday to the pharmacy to collect the medications because they either haven't come on time, they've had to do a special order, or she's forgotten, they've nearly run out. They have a sharps box because the collimicin in particular has got a metal collar on it, and so they've got to dispose of that. Some of the times they do have to use needles, but not very often. So that we have to make sure that's kept in the right place, and then who's going to give them the sharps box, who's going to take it away, and who's going to keep the place safe. The collimicin are all in little glass vials, and so we have to dispose of all the glass safely. So they've got an empty feed bottle, which we cut the top off, and we put all the glass bottles in there, and then they can go into the glass recycling. And then they've got a 1 litre bottle of saline, which they use for the flatus tube, and we put all the plastics in there, and then they put the top on and put that in the recycling box. But there's a lot of waste. There's a lot of cardboard arrives. There's a lot of paper packaging and plastic packaging with the medications that come. The metal strips that the drugs are in, if they're tablets, all have to be disposed of as well. They need a lot of syringes, and we've got 2 drawers full of syringes of different sizes, because he wants one size for the buccal midazolam if it's not in the syringe, or any nystatin or anything else like that. He's got 2.5, 5 mil, 10 mil, 20 mil, and 60 mil syringes, just in case they're all needed either for the oral feeding, oral medications, or for the flatus tube. So they have to watch how many they're using, and at home they have to wash them all out when they've used them, and they use them until the markings on the syringe start to disappear. And then once they start to disappear, they're deemed unsafe, and so they get rid of them and get a new one out, which goes against the grain when the nurses are there, because we always want to open a fresh one and saying, well, that's what we're used to, and we know that it's safe and hygienic. So we've got to make sure they're washed out properly in washing up liquid, and then that they're air dried to make sure that they can sort it all out. So when do they order the syringes? Where do they order them from? And how long will they take in arriving? When they've got them all, they've got to store it all, and then they've got to dispose of the syringes properly, because there's classed as clinical waste, but they haven't got a clinical waste bin, and they don't have clinical waste bags. So some of them they have been putting into the recycling, and some they put in a big box and take down to the local household tip, which always seems weird to me. The syringes arrive in great big cardboard boxes, and the family have got to try and store these boxes until they can empty them into the drawer, so that they're all readily and quickly available should anybody need one in a hurry. In order to feed him, we have to have the peg feed sets. So again, they've got to be ordered and then stored. He's got to have milk bottles delivered full of the milk that he's going to have. He has Farrell valve sets, and they've all got to be ordered, delivered and stored. And again, they come in great big cardboard boxes. And I said, when I walked in the other week, the hall was full of another load of cardboard boxes. I said, what are all these? And she said, the latest delivery. They don't seem to be sending in small boxes. Ideally they could do with a weekly delivery, so they could have a rapid turnover, and they wouldn't need so much space to store all of this stuff. He can have oxygen when he goes cyanotic, when he's having seizures or he ceases breathing during the seizures. And the major problem we've got there is the prescription was completed by the respiratory consultant when he was about 5 years of age. The respiratory consultant saying there's nothing more we can do for his chest, so they've discharged him to the care of the GP. The GP saying, I don't know enough about respiratory medicine, so the prescription has never been altered in the last 10 years. When he's really poorly and his SATs drop and he goes blue, and his periphery and his feet, toenails and fingernails are very blue, we give him 5 and 6 litres of oxygen a minute for less than 5 minutes, and then start dropping it back down. But when the ambulance come, they give him a higher dose, because they can do and ignore the prescription, but nobody seems to want to update anything. We've got 3 different types of cylinders in the house to give him the oxygen, and we've told them where to store them. They're going to be handy for us to use, but they're also going to be in a safer space so nobody walks into it or knocks it all over. She has trouble every time trying to get somebody to reorder the oxygen, and then come out and check the cylinders to say, yes, you're all right with what you've got. He's got a little portable one which we can use when we take him outside into the garden, or if we take him out for a walk, or he goes to the hospital. And they've got an oxygen bottle now at school, because they've got more than one child who sometimes has oxygen, but they've got a physiotherapist there who can administer the oxygen supply. He has oral suction, so we've changed the type of catheter that we use to suck his mouth out, and making sure that we know it's the right size and we're not going to damage his gums or his teeth or his tongue while we're trying to do it all. Same thing applies. She's got to know where to put this stuff, the syringes and the tubes and the filters for the suction machine. It's electric. It has to be charged overnight minimum, so that it will last all day while he's actually in school, and sometimes has to be put back on it charge while we're working with him, in order to make sure that it's safe and it's the right pressure setting for him. She's had problems in the past trying to get the PAT testing done, because they're saying, well, he's at home, we don't do that sort of thing. So they've now asked if the school can organise pad testing so they can use the suction machine in the school. But when he leaves school, who's going to do the pad testing? We keep different records, and the main ones are his seizures, because you never know when they're going to occur, what type he's going to have, how long they're going to last, how they're going to affect him. We quickly use the vagal nerve stimulator to try and inhibit the vagal nerve to reduce the severity of the seizures. But the problem then is sometimes it becomes less effective. The interesting thing for me is when I did the training, we were taught to go from the top left shoulder down towards the centre of the sternum. The parents have been taught to do it the opposite way and go from the neck across to the armpit. Some of the carers have been told that they're supposed to do it straight down vertically. I don't know whether it is more or less effective, because I don't know if we get any evidence to say it does work or it doesn't work. He has to have different scans, tests, and goes to hospital or clinic for appointments. And in order to do that, they've got to have the carer, as in his mom or his dad, an escort to go in the vehicle with him, and they've got to have the records that they've done so that they can discuss with whoever they're going to see. And in the adult hospital, they've got clinical nurse specialists for epilepsy management, but he was recently in hospital for 5 days and they never saw the clinical nurse specialist once in the 5 days. So they get worried, because will the appointment be with an appropriately qualified person? Will it be with somebody who actually knows the condition and understands, or somebody who's just going to say, let's try this, without worrying about the consequences? If they only change one type of medication, is there an interaction with the other medications he's on, or the timing? For example, he had to have some antibiotics, and the antibiotics were an hour before food or 2 hours after food. So trying to adjust the timings with his feeds, and then he couldn't have anything overnight because he's on an all-night feed. So that causes problems. They've got a saturation monitor, they've got a blood pressure machine, they've got the oxygen machine. So when he's poorly, they then put him onto constant monitoring. If the ambulance is called, they shove him straight onto ECG monitoring as well, so that they can decide and interpret the findings that they've got there. Because he can't move himself, he's hoisted into position, either onto the bed, from the wheelchair, from the bed into the wheelchair, or sometimes up in the air so we can change the bed or whatever else. Again, there's been problems trying to get the physiotherapists and the occupational therapists to agree what type of sling, what material and what size we should be using. We've had to make sure people know to check the wear and tear of the sling, because the family is saying we can't get them easily replaced. But we're having to say to them, you know, if we're unhappy and we think it's frayed, then somebody's got to do it. And the physiotherapists are saying, it's not my job. I'm just advising you that you should be getting a new sling, and the family are having trouble with the surgery, trying to find out how to get new slings at this point in time. Because he's in a wheelchair, wheelchair services provided a wheelchair, but he's outgrown it, and it's taken 9 months to get him measured for a new chair. He has a moulded chair because of his spinal problems, and that's caused problems trying to put him in a suitable position in order to make sure that he doesn't get any sores, that he isn't in a particular trapped in the thing. But you can also put the sling behind him, because at school they leave the sling underneath him all the time. So when he comes home, we put him on the bed in order to get the sling out and free up his skin, so he's not getting too much of a reaction from there. The wheelchair is quite complex because it's got facilities to put oxygen on, facilities to put weather equipment on. So you've got a hood and you've got to have a screen all over him. So he's been moved around outside. He's protected from the elements. And so some of that equipment is not provided by wheelchair services, and the family have had to do fundraising in order to buy extras in order to try and keep him safe. So while he was in hospital, I was paying attention to the discharge nurse and trying to record in my head what sort of things they had done. And some of the things I found were they were concentrating on the most obvious. Now, you know how to do his drugs, yes. You know how to do suction, yes. Nothing else about what's going to happen when you go home. Just please take him out of this ward because we can't cope with him. And it seems quite sad in that sense. So I would prefer if we were able to create a checklist that went with him, and that when he went to clinic or whatever else, we could have a holistic assessment, holistic approach to his management, so that every aspect was thought of, if not necessarily discussed in detail. And then it could be, we could write comments and saying, refer to the GP, get the medical secretaries to contact the supplies department to say, let's change this or whatever. Then sometimes there's equipment that's no longer needed because it's too small, or it's been changed or updated or upgraded. How do we get rid of it? How do the family get stuff collected? Because it doesn't come like an Amazon parcel where you can then send it back the next day. And so they've then got old stock, new stock in this small house that they've got with the child. He's got the equivalent of a hospital bed, which they've just changed because he's now an adult. And unfortunately, it doesn't rise high enough for the family. And the mother, being quite tall because she's 6 foot, has to bend her knees to try and do the flatus tube when he's lying on the bed. And I'm worried that she's going to get the backache if she's not careful. But we suggested that perhaps they could put bed blocks underneath the 4 corners to lift it up for them. And they said, no, that would be unsafe. But the person who delivered the bed doesn't know who needs to do a risk assessment on the house, on the family, and the size of the carer, as it were, to try and say, yes, we can do something for you, or no, we can't do something for you. So if we haven't got a checklist, how do we know that we're preparing the family to go home when he's in hospital? The family have got a routine where they've got to get up at 5 a.m. to get started and hopefully get to bed around 10 p.m. and hope that he sleeps all night and doesn't have too many seizures. The situation then is that they're very tired. They're always on edge because they don't know what's going to happen with the seizures, with the equipment or the carers. Is somebody going to turn up to help? And if they turn up on time, they've had carers who've turned up who can't do peg feeding. They don't know how to use the vagal nerve stimulator. And they thought they'd just come to sit and help look after a child. They can't do oral suction. And so she's had to say to the company, you know, this carer isn't appropriately qualified for the type of child that you've sent them to look after. But the adult district nurses are saying, well, we don't order these things all at once. And you're saying, well, this is the child, this is the family. We've got to have a holistic approach to everything that we're trying to deal with. With COVID in particular, and because it's now turned out to be positive for MRSA, the family have had to start getting more personal protective equipment and making sure that the stocks are being well managed. They've had to, again, it's something else they've had to order and store, and then they've got to make sure that there's safe disposal of any equipment that they're doing. The carers need to know how to use the equipment, and we need to know that if they've used it and they've got concerns, that they actually will record the things properly so that we know that they're going to be doing it when they know they should be. With the moving and handling, I've already mentioned some of the elements, but the key one that I'm always watching for is the PAT testing. So I know he's got a hoist in the bathroom and he's got a hoist in the his main bedroom. But you have to lift him off the bed, put him in the wheelchair, wheel him into the bathroom to hoist him back up to put him in and out of the bath. And I'm always careful to watch when the PAT testing dates are on there and keep saying to her, can you get somebody to come and do the PAT testing so we know it's still safe for us to use? And we have to make sure that any carers or family who want to come and help, because some do occasionally offer, whether they know what they're doing and if they've got some sort of training that we can offer. But then who's got to pay for the training? The mother has got a small budget now from the community care services, but some of that then has to be spent on training staff, and hopefully those staff will then continue to come to look after him. I mentioned that he's got a sluggish bowel and he has flatus tubes passed in order to try and reduce the gas and distension in there. And again, one of the problems for me personally is that when we were taught how to do it by the clinical nurse specialist, she said we could use 60 mils of normal saline warmed up. And we have to have a thermometer, a lotion thermometer there to make sure it's the right temperature. In the last 5 years, the child has grown, but nobody will increase the volume of water to try and insert into him to make it more effective. And I keep trying to say to him, he ought to be on at least 100 mils now, if not more. But the clinical nurse specialist, because he's now at home saying it's a community aspect, the community nurse is saying, well, we don't know what to do, so we best not change it. And I'm saying, you know, when he goes over to the adult care, the adult nurses might say, well, yes, now we can use 100 mils or 150 mils, but we don't know what to do with that. And again, you've got to try and look at the temperature of the fluid that he's using. And again, it comes in great big boxes, great big heavy bottles for them to store and then proceed with. And they've got to use it all and get rid of all the bottles. And sometimes they've actually run out of normal saline, and the pharmacy have advised them that how to make up their own liquid, the litre solution of saline in order to use for this procedure. When it comes to record keeping, the only drugs that the hospital seem to be worrying about is how often have you used the midazolam. And sadly, as I was in hospital recently with the adult services, the discharge letter that the family were given was wrong, as most of the medications have got the wrong dose or the wrong format. And one of them in particular was the midazolam to be used for his status, and it's the wrong strength, and so they can't use it. The pharmacy don't want it back, and so they've had to have another delivery of the midazolam. They've got to take it all back to the pharmacy, but the pharmacy is saying this is a hospital dispensation. The hospital is saying no, give it to your local pharmacist. So there's a lot of things for the family to consider, a lot of things for the family to worry about, as well as looking after the child, as well as trying to live a life. Both parents try to work a little bit part-time to keep themselves mentally active and socially and financially viable. And so it's quite an exhausting time for all of the family to be involved with. So I'm hoping I've given you some things to think about there, and I've tried to identify some key questions, but I'm very sorry to say that I'm going to have to stop because I need to get off to this funeral. So Katrina and Fiona very kindly offered to go through the questions and answer anything that you may wish to raise. If there is anything that you wish to come back to, then don't hesitate to come back to me or through Fiona and Katrina, and if I can, I'll always email that I can do anything that I will.
Thank you, Norman. You really do need to go.
Thank you very much.
Thank you.
Good luck to everybody, and all I would say is please promote paediatric nurses for paediatric patients, because we've got to promote our profession. Thank you very much and good luck.
Thank you. So unfortunately, as Norman left, his slides left too. But I think one of the things that, having seen him develop the presentation, that I really resonated with me was the actual timing of everything that this child, young person, needs to happen in his day. And when you actually think about the family, and the things that we didn't add in there was, you know, when do mum and dad get showered? When does the washing get done? When do the bins get put out? The usual things that we manage to fill our days with. So regardless of whether we're at work, our days are always full. And I always have incredible admiration, but also amazement that families manage to fit in quite so much of that care that we've heard about. So in terms of the family, and I think as professionals working with a family, my question would be, maybe take Norman's slide and add in sort of our own activities of daily living for the rest of the family. This is a family that has older children, so doesn't have to get other children off to school to remember that today is book day or whatever it is that they have to do. And if any of you manage to have medical students with you, I always think it's a really good example to get them to think about what life is like, and then to take into consideration some of those other challenges that Norman has mentioned, in terms of the wrong medication, supplies all arriving at the same time, everything that he's told us about today. But in terms of what he was going to ask you, and sort of opening it up to conversations now, if I can just get my emails opened on my telephone, one of the things that he specifically
questions in the chat.
Oh, have you? Oh, thanks, Fiona. So they're there.
I'm putting them in.
Oh, right. So one of the first things that he asks is, while the family are in hospital, the family have to stay all the time, as the nurses are asking the family to manage all of his medication and drug security. And Norma's sort of question to us all is that safe practice? And having recently sort of had a relative on an adult ward, trying to manage her own medication, I would question whether it is safe. So, I mean, any views on that? I think, you know, just sort of chip in, really. Is that something for those of you who are working in hospital still? Is that what happens when children come in, that families are taking that, and how do you balance that with professional responsibility? So nobody willing to share? Hi, Jean. Hi, Jean. I think you're on mute at the moment.
I haven't spoken because I can see Angela. I think she wants to speak first. Go ahead, Angela, and I'll speak afterwards.
Not necessarily, but I suppose I've got a few comments, I suppose, by the whole, you know, what Norman so eloquently presented, actually, and I actually feel quite depressed about the whole thing. And I think, you know, there's something here about, you know, that balancing, isn't there? Balancing of everything, really. And I think as nurses, I mean, you know, we do really have to consider all of the time what our code of conduct is, and patient safety is a massive part of that. And, you know, I think it goes back to what our role is compared to that of the parent, actually. I mean, I think we're very fortunate at times in so much as, you know, parents are there, but, you know, but it isn't their responsibility. It is about that collaboration with those parents, and, you know, the agreement of what they do and what they don't do. And it's not about taking over the parenting role or them taking over the nursing role. But I've got a lot more to say as well, just apart from that. I mean, for this whole thing, I mean, there were several things where I just jotted down duty of care, you know, and of course this young man seems to fall under, you know, consent, and of course what happens when it comes to those reviews that he needs to have. And then of course there's a big thing around the transition and the importance of appropriate healthcare transition and who leads on that and what it really means. It doesn't mean transfer, it does mean a process of transitioning. And then of course my other question was, you know, who, where was the key worker for this young man? So I suppose probably more questions than answers, but yeah, it really did demonstrate the complexity of families versus healthcare, working with, and everything else. I'll be quiet now.
Thanks, Angela. If I go to Jean and then Fiona.
Thank you. Hi, Angela. You actually have put forward the things I was thinking of, and the two main things are the key worker, care coordinator, which usually ends up being the parent anyway, so they do not have any relinquishment of that role. And I think what you said is really important about getting the balance and recognizing and respecting their care coordination for their young person, but also being really mindful of if their health fails and deteriorates, and Norman was saying about back care and the bed and the hoisting, then we are also failing the parents. A carer's assessment is integral to the whole family dynamic, and if they don't get that carer's assessment thoroughly done, then the carers won't receive the help they need. The other thing just to say is that many charities have scoped parents' views on can I just be mum or dad? Do I absolutely need to have all these other roles as well? Hospital and medication risk assessments, somebody should be responsible for those risk assessments. There are some drugs that the parents are encouraged to give and be responsible for. So again, it's the risk assessment, who is taking the risk for safety in a clinical area. In a hospice, if the parents are staying, the parents do usually give the medication if they're there. It's an agreement. It's not always a contractual agreement, and it's only when things go wrong that there is investigations and people feel as though they didn't absolutely uphold their duty of care. The one other thing I want to say is about charities appointing nurses especially for transitional care, for these transfers of care. And it would be worth, somebody having a look, doing a scoping review of all the articles, the research that's been written to see what are the fundamental issues. I do think from evidence that we've given into different devolved governments, that the issues have been there's too much variability, there's too much postcode lottery. The children are totally unique. One size does not fit all. So I just wanted, those are the points I just wanted to make. Thank you for the opportunity to do that.
Thank you, Jean. And I'll just sort of draw people's attention to Brit's point about responsibilities. So thanks for putting that in the chat, Brit, sort of recognising that while the families know the medication's better than most, not feeling that it's safe practice from the point of nursing care, because as nurses, we have that duty of care for the patient safety and medication management. So that's the point from Brit, which falls into mentioning that, you know, that the duty of care aspect. And then from Simon, recognising that there are ongoing challenges in terms of children and young people's continuing care, but now with moves towards all age continuing care teams, that should help with transition moving into adult services to be more consistent. So I think that the challenge for all of us is that this is the reality of care for just one family that we've heard about today. And I don't know whether others are getting their sort of news messages flashing up on other devices telling us that NHS England is going to be scrapped, according to Sky News, to bring health service back into the heart of government. But that means more change. And the challenge for all of us working in that NHS is to ensure that the day-to-day care of young people and children and families and adults and everybody else is actually safe and ongoing. So we may see changes in structures, but we won't necessarily see changes to the challenges. But Fiona, you've got your hand up too.
I have to say I'm absolutely horrified what has happened to child and family centred or focused care and negotiated care, which clearly was happening when I was last in a service role. And I think perhaps the ABPN could do something around some of the fundamentals around children and young people's care, including transition from young people's services to adult services. And Angela, I know I'm going to put you on the spot now. I know that you've done work in this particular area. So I hope to be able to, on behalf of the ABPN, contact you subsequently to do some of that work and potentially a subsequent webinar.
Thank you, Fiona. I won't charge too much, okay?
I mean, I think for everyone, because we are coming towards the end of the time this morning, but another point from Simon is that as children's nurses, we're just one part of that team and needing to take the holistic view of the needs of each child and young person. We're working in multidisciplinary teams. We are working with trained carers, and hopefully that can ensure that the care remains consistent throughout that package of care. But I think, you know, that challenge to get that sort of wraparound service that he's talking about is, it is a challenge for us. That challenge isn't going to go away. But what I'd like people to do is maybe when the slides are up on the website, the ABPN website, hopefully I'm looking for Fiona to sort of correct me if I say later today or tomorrow we will get those slides up and sharing them with your teams, and maybe looking at some of the challenges rather than focusing on the challenges within our own teams. Sometimes it helps, doesn't it, to have a case where you can sort of quite safely be critical and say, well, we could do it differently and we could do it this way. And yes, Simon, recognising that it is a worrying time for the NHS world and those working in NHS teams, but there will be further detail. And I think at time of change, it's always difficult, isn't it, when we don't get that detail. And Fiona, you've put in the chat box there that if you have any issues that you would like the ABPN to address, please contact her. And yes, she's confirmed that the slides will be there by this afternoon. But if you can think about it, and as I say, maybe add in some of the reality of a typical day of just any person. And Bernie, I think I'm going to give last word to our president of the association, is saying that she thinks the very sad thing is that it isn't an isolated situation. And I think that is very true. There's a lot of good practice, but also situations where children, young people and families fall through the gaps, and the gaps are getting bigger. So we have the evidence to improve things, but the resources are being stretched, and I think it's how we can work together to make the most for those resources. And if we think about Norman's description of what is happening, I think we can see that there are huge gaps in that young man's care. And not only are there gaps in the care, but there's an awful lot of overlapping, unnecessary things happening, such as the over provision of certain things. So, and Amira, the webinar is being recorded and it will be going up onto our YouTube channel, hopefully. So just keep an eye, I would say, on our website. To sort of see when that's actually happening. That's sort of, we haven't got the person who'll be doing that on the call at the moment. But yes, we will have the recording at some point, but the slides are there almost, this afternoon. So thank you all. Fiona and Bernie and Jean, any points from you?
Just to say thank you, really stimulating thoughts, lots of food for thought. Thank you.
Fiona and Bernie.